All right, welcome back. Chapter 17, Cardiovascular Emergencies. We're going to cover AV blocks. We're going to start on slide set number 174 of the focus slides. AV blocks, otherwise we're talking about bradycardic rates. AV blocks, the SA node initiates the impulse. We discussed that in the anatomy physiology of cardiovascular, which proceeds through the atria and ventricles, resulting in heart contractions. Occasionally, impulses are delayed more than usual and completely blocked, causing AV blocks. The first degree AV block, it occurs when each impulse is delayed slightly longer than the normal, resulting in a constant PRI that exceeds 0.20 seconds. That's 0.20 seconds. Remember when we talked about in our structure of the EKG how each one of those big boxes are 0.04 seconds, and there's 5 of them in there. So the PR interval is going to be greater than 0.20 seconds. As you can see on this representation, here's your P wave, okay, and here's your PR interval. So the distance, if you go from here to here, you have 1, 2, 3, 4, 5, 6, 7, roughly 7 boxes. Okay, so this is around 0.28 seconds, somewhere between 0.28 and 0.24, and so therefore is greater than 0.20 seconds. It's considered the least serious type of block, but is often the first indication of damage to the AV node. The rhythm is usually regular with minimal variations of R to R intervals. Regularity depends on the underlying rhythm. It has an upright P wave followed by a QRS complex, vary in size and shapes. The PRI is 0.20 seconds or greater, and it's constant in duration. The QRS complex is 0.11 seconds or less. These are rarely treated. These are ones that patients have on a continuous basis that they live with, but their cardiologists are watching it. So, up here we talk about AV blocks, otherwise bradycardia. This is a heart rate that runs somewhere between 50 to 60 beats. Okay? When we talk about AV blocks, in the first one, PRI is greater than 0.20 seconds. Okay? I want you to remember and focus on PRI, because as we progress, it's going to make sense that if we just identify the PRI, you'll know what it is. Next one, second degree AV block type 1, which is also called a Winky block or a Mobitz type 1, either one. I mean, those are people that identified the rhythm. But if you think of it from second degree AV block type 1, you'll be in the ballpark, because the second degrees have a type 1 and a type 2. This occurs when an interruption in impulses conductions occur within the AV node, bundle of His, or the His-Purkinje fiber system. This prevents the impulse from proceeding to the ventricles and generating a QRS complex. The interval between P waves is regular, and an upright P wave precedes each one of the QRSs. The interval between the P waves is regular and upright, and again, the ventricular rhythm is irregular with a prolonged R to R interval, with the last QRS complex before the blocked P wave and the QRS after the first unblocked P wave. So, if we look at this representation, you can see here, and what distinguishes is the PRI gets a little longer each time. A little longer, and then boom, there's an absent QRS complex. Okay? Depolarization was interrupted and did not happen because ultimately the P wave or the SA node got so far out that it couldn't generate an impulse. Okay? So, again, PRI progresses until a QRS drops. I want you to remember that. Second degree type 1. PRI progresses until 1 QRS drops. Again, PRI, you're centered around the PR interval. So the PRI starts out with a normal limit of 0.12 to 0.20 seconds, but gets longer and longer and longer until it drops. The P wave is then followed by a QRS complex with normal PRI, and the pattern repeats itself until the QRS complex is completely dropped. The key to recognizing the second degree AV block type 1 is observing that there's more P waves than there are QRS complexes. Also, that the rate is irregular. You can see this. It's irregular. There's a missing beat. If I feel your pulse and you're in this rhythm, I can feel the missing beats because your heart rate will be irregular. And the way I identify that this is a type 1 is that the PRIs are progressive until it drops 1. Now, second degree type 2, this is also called a Mobitz type 2, second degree AV block. It is more serious than the second degree AV block type 1. Its impaired conduction occurs at the bundle of His or more commonly in the bundle branches. An intermittent block is characterized by regularly occurring P waves and then an abrupt appearance of at least one P wave that is not followed by a QRS, but most commonly it's more than one. Case in point, look at this strip. These are all P waves. Oh, great. That was not good. All right. Recover. Get that here in a little bit. These are all P waves, okay? The P waves, there's multiple, but notice there is no progression. So PRs are constant until you get one or more drop QRS complexes, okay? So look, instead of being progressive, they're the same. This PRI, this PRI, this PRI, and that PRI are all constant. And then it drops one or more QRS complexes. So, type 2, PRI constant. They're all the same until one or more QRSs drop. Period. Everybody got that? Again, we're only talking about PRI again. That's it. Now let's talk about third degree block. Third degree AV block is also called a complete heart block or complete AV block. It occurs when all impulses reaching the AV junction are prevented from reaching the ventricles and generating a QRS complex. A secondary pacemaker assumes the responsibility for the impulse. Look for non-conducted P waves in the absence of any relationship between P waves and the QRS complexes. Now, one of the biggest things that you'll see out of this, 100%, is that the R to Rs are consistent. It is not irregular. This is a regular rhythm, but it's very slow. Okay? It is a very slow rhythm. Plus, look at the PR intervals. They're all different. PRIs have no relationship. The rate is regular, but PRIs are all different. Okay? So, third degree. PRIs all different. It is a slow rate, and your patient is usually very sick. They're about to buy a pacemaker, plain and simple. That's the only fix for this. Okay? That is the only fix. Artificial pacemaker rhythms, when you start picking up some weird things, an artificial pacemaker rhythm is a pulse generator. As you can see on this strip here, you can actually see the pacer spikes. Here they are. This is a heart that's being generated, a heartbeat that's being generated or stimulated by the pacemaker. It's taking over the P wave. Okay? It shocks the heart and makes the ventricle beat. It's kind of every time you shock a frog in science lab, it jerks. Well, the same thing. This is taking over as the pacemaker because you may have a constant pacemaker, you may have a demand pacemaker. Demand pacemaker is when the patient needs it. Whenever the patient's P wave or SA node fails to fire, it will fire for you and create those ventricular beats. So, wire electrodes are attached to one or more of the chambers of the heart, and a pulse generator of a permanent pacemaker contains a programmable hardware and provides that for them. It causes that very unique spike. Can we do pacing from the external? Absolutely we can. Transcutaneous pacing, or TCP, is the primary treatment for a third-degree heart block. Artificial pacemaker rhythms, again, single-chambered pacemaker. Very unique. You have dual chamber pacemaker, which is on both of the atriums, and then you may also have biventricular, where it powers, it paces both ventricles. So there are two rate types. You have a fixed rate pacemaker, which is seldom used today. It generates a pacing impulse at a pre-programmed rate. Then you have the demand pacemaker, which is equipped with a sensor that generates a pace impulse when the patient heart rate has dropped below a predetermined rate. If a malfunction occurs, an implanted pacemaker malfunctions. Types of pacemakers include the following: failure to capture. Pacemaker spikes may be visible, but they're not being followed by a QRS complex. Or there's a dislodgement of the wire connecting to the patient's heart to the pacemaker, possibly even battery depletion or ventricular perforation. Failure to pace is indicated on the ECG by the absence of a pacemaker spikes at expected times. Patients with pulse generator failure, broken lead wire, disconnected wire cable, or battery depletion. Failure to sense is the indication of the ECG that the appearance of the pacemaker spikes within the P waves QRS complex of the T wave. This is a malfunction. Usually it's caused by a power failure or pulse generator failure, broken lead wire, an excessively high sensitivity setting, or battery depletion. Then you can have oversensing and runaway pacemaker. Oversensing is indicated by ECG that's by the occurrence of the pacemaker spikes at a slower rate than the pacemaker's preset site, or by the absence of pace beats even though the pacemaker's preset rate is faster than the patient's rate. Runaway pacemaker is a very tachycardic pacemaker that just is way too fast. Something's gone wrong with the sensing part of it, and of course in any of these types of failures, patient needs to be seen at the hospital as quickly as possible to get it to slow down or to repower it. How do we take care of it? If you have pacemaker failure and the patient's bradycardic, very simple, transcutaneous pacing. Easy enough to do. All right, with that, we're going to go ahead and stop here. This is the end of AV blocks, and we'll be starting up on slide set number 183 in a few minutes. That will be lecture number 6. So currently we're ending lecture 5 with AV blocks, and we'll see you in the next few minutes.